Hi everyone, my name is Sam Willis and I'm a senior lecturer for the Australian Paramedical College. Today we're going to talk about the time critical patient. Now, you guys will probably have read a little bit about time sensitive, time critical, critically unwell patient. They generally all mean the same thing. And what it's referring to is those patients who are so acutely unwell that every single second you delay getting them to hospital can mean the difference between life and death. Now, the good news is approximately 80 to 90% of the patients we attend as a state ambulance paramedic don't actually require time-sensitive responses. So this presentation really does help you guys to identify what types of patients come into the time criticality patients and to help you guys to understand the nature of managing a time critical patient. So the aims of this session are for us to take a look at what is the definition. What does it mean to have a patient who is time critical? Recognize time critical features in patients presenting with what we call the 4 H's and 4 T's. Now, those of you who've already done the diploma or done the workshop 2, which is the diploma, or maybe you're working towards workshop 2, you will have already heard about this notion of 4 H's and 4 T's. The 4 H's and 4 T's are reversible causes of cardiac arrest. And I personally thought it was quite timely that we use the H's and T's to structure this session on, because they are reversible causes of cardiac arrest. And it doesn't really get more time critical than that. So we're using the H's and T's to structure this lecture. And of course, we will discuss methods for managing time critical patients. Okay, so let's take a look at this case study, which exemplifies what we are talking about with a time critical patient. So you are called to a road traffic collision. So you're called to an MVA, RTC, whatever you want to call it, motor vehicle accident, road traffic collision. On arrival, it becomes clear that a male has been struck by a vehicle and the male is now laying on the ground. As you assess him, he is conscious but in a confused state. He looks pale, and he is also holding his abdomen, which looks swollen. So try and picture it. You are the paramedics. You've arrived on scene. There's lots of people panicking, saying, hello, he's over here. And now this guy is laying on the ground. He's been hit by a vehicle, and he's confused, he's pale, and he's sweaty. Now, that's not a good sign. So let's talk through this in a little bit more detail. So as you arrive on scene, you are going to do your primary survey, danger response, airway and C-spine, breathing, circulation, disability, and exposure. You're going to call in a situation report to dispatch because they'll need to know about it. Then you'll go to assess him following the primary survey approach. But in terms of time criticality, it's your responsibility to try and assess, is this person sick or not sick? And if he's sick, you need to get going. Because let's be realistic, guys, some patients do not respond well to taking your time, waiting 40 minutes for a second crew if the local hospital is only 10 minutes away. And these are the decisions you've got to make. So we've already said that most patients do not require emergency care, but instead call for help when an existing condition has become exacerbated. So with regard to your history taking, it's so important that you're able to do a history taking and establish what condition they have and how often it becomes exacerbated and what are the trigger points that makes it exacerbated. For those who do require urgent care, the paramedic must make safe decisions quickly and must be able to prioritize the care they deliver. So what this means is using all of your clinical skills, your history taking, your previous experiences, you've got to be able to work with your crewmate, and you've got to communicate with your crewmate, with your patients, and you've got to use all your knowledge, of underpinning knowledge of history of body systems, and you've got to be able to prioritize the care that you deliver. In other words, do you need to give oxygen because they're looking pale or have oxygen saturations of below 92? Do they have a tachycardia? Is there anything that you can do for that tachycardia, or is it just something you have to act quickly with? You have to establish if there's any internal or external bleeding. So notice how you're trying to assess and look at your patient, use everything in your environment to try and work out what you can do to help this patient. The first step is to be able to recognize time critical situations. Now we are using in this presentation slides, we are using the 4 H's and 4 T's as the reversible causes of cardiac arrest. But when we're talking about time critical situations, it's any situation that you as the paramedic think that if you don't move quickly enough, your patient's going to deteriorate and have really poor prognosis, have poor outcomes. So when we're defining time critical, let's just be really simple, but be clear that time critical means it's anybody who is acutely unwell, that the speed at which the paramedic treats can mean the difference between life and death, or even loss of limbs. Remembering that time critical means something in that situation is responsive to time. In other words, let's say your patient has sustained a nasty sporting injury and they can't feel that limb. Maybe there's no circulation going into that limb. Then it's crucial that you get to the major trauma center quickly. So it's not just about the patient's going to die, but it's also about the loss of limbs as well. So time critical signs and symptoms then: catastrophic hemorrhage, internal hemorrhage, hypoxia, confusion, cyanosis, tachycardia, bradycardia, hypotension, or cardiac dysrhythmias. So this is not an extensive list. This is just your typical signs or symptoms that will help you as the paramedic to recognize signs of time criticality. So the first one is catastrophic hemorrhage. Now, you will have probably seen this term used before within your studies. We're using the word catastrophic to mean that if you do not plug the hole, stop the bleeding right away, find it and plug it, the patient's going to die quickly. Remembering that catastrophic hemorrhage may be something that you see when you arrive on scene. And on most occasions, if it's catastrophic, you don't have to look too hard to find it. But just remember that it could also mean catastrophic internal hemorrhage as well. Now, internal hemorrhage is a lot more difficult to try and find. But what you have to assume that if you are approaching a patient and they're confused, sweaty, pale, there's a possibility for internal bleeding. Now, internal bleeding is one sign of one type of shock, hemorrhagic shock. But shock, which is defined as a lack of tissue, a lack of oxygenation, or a lack of oxygen at the local tissues. Some people will define it as a lack of oxygenated blood at the tissue, but shock just means there's a lack of oxygen at the level of the tissues. And that can be caused by a lack of an ability of the heart to pump effectively, which is cardiogenic shock. It can be distributive shock. In other words, like internal hemorrhage, there's a lack of oxygenated blood at the level of the tissues. Hypovolemic shock, which is a redistributed fluid. There's neurogenic shock, which is a lack of the nervous system to control the vessels appropriately, therefore you get widespread vasodilation. And there are a couple of other classifications as well, but they are the key ones. So internal hemorrhage is not something that's always easily identifiable, because if you're looking around to try and identify some type of blood loss, but the patient's looking confused and they're looking quite pale and sweaty, you know that some kind of shock is occurring. But if there's no external bleeding, you've got to consider one of the other types of shock. Now, hypoxia, low levels of oxygen, is something that we've just mentioned in shock. So the shock is basically low levels of oxygen at the tissues. But hypoxia can also be caused by non-oxygen atmospheres as well. So for example, somebody who is intentionally trying to harm themselves by suffocation, by going into non-oxygen atmospheres, for example, by putting a pipe into the exhaust of a car and putting it into through the window to try and intentionally kill yourself. Now, that can happen, and I've actually been to one of those situations, but it was many years ago. Today's modern cars are actually much more safe than they ever have been, so it's much more difficult to do that type of thing where you basically overdose yourself on carbon monoxide. Also think about typical industrial environments that might be low on oxygen as well. But you know, hypoxia basically means low levels of oxygen at the tissues, which ties really nicely in with shock. Confusion and reduced ECS. So if your brain's not getting oxygen, it's going to be confused. Cyanosis, so paleness to the skin or even blueness to the lips. Tachycardia, so as your body is trying to get more and more oxygen, it will do a number of things, including speed up the heart. And something that's not on this list is speed up the breathing as well to try and get the oxygen in. Eventually, at the end stages of shock, when your body can no longer compensate, you will end up with a sense of bradycardia, which is decompensated shock. Hypotension, again, sign of decompensated shock or distributive shock, whereby fluids have moved from one space to another. And a really good example of this is with anaphylaxis, where you get a shift of fluid, a shift of movement of fluid from the intracellular space to your extracellular space. And cardiac dysrhythmia as well. Just remembering that your heart and your electrical conduction system in the heart is extremely sensitive to oxygen and low levels of oxygen. Okay, so the time critical situations ties in nicely to what we've actually been talking about. Hypoxia is one of the actual reversible causes of cardiac arrest. So think about hypoxia as a way of managing a patient. Hypovolemia, hypo or hyperkalemia and metabolic disorders, tension pneumothorax, cardiac tamponade, toxins, and thrombus. So let's talk about those in a little bit more detail. So we've actually talked in some detail about hypoxia, definition and causes. Hypoxia simply means low levels of oxygen in the tissue. Hypoxemia means something similar, a low level of oxygen in the blood. And to be honest, we tend to use hypoxia to mean hypoxemia. And generally speaking, as a paramedic, it doesn't matter which term you use. But just know that from a medical perspective, they do mean slightly different things. Causes of hypoxia from a paramedic perspective can be caused by blocked airway. So the tongue, for example, being the biggest muscle in the upper airway, which can block the airway. Respiratory diseases such as asthma, COPD, trauma, and non-oxygen atmospheres. The way we would manage this is by opening the airway, providing high flow oxygen, providing artificial ventilation, for example, with your bag valve mask ventilation, which is something that you guys will be able to practice at workshops 1 and 2. And of course, you can provide drugs such as salbutamol and ipratropium bromide if it's within your scope of practice. And of course, for life-threatening asthma, you can also give adrenaline as well. And then there's CPR in cardiac arrest as well. So that's hypoxia. And of course, when you're doing workshop 2 and you're trying to reverse these causes of cardiac arrest, you need to be mentioning to the trainers, okay, I'm now looking at the causes of hypoxia and doing my best to reverse those. So hypovolemia means low blood volume. Well, actually low volume. It doesn't just relate to blood. It can mean other body fluids as well. And just remember, guys, that when your patient has been significantly burned, you will also end up with hypovolemia. And when that happens, you don't just end up with low blood pressure and signs of shock. You can also end up with serious dehydration as well. Nervous system damage, burns, other fluid loss, all of these are causes of hypovolemia. Nervous system damage is something which is a sign of or even caused by the nervous system basically controls the venodilation. So you have receptors and nerve endings that are in, they cause constriction. So of course, if you've got a problem with your nervous system, you're going to get problems with constriction and dilation in the most appropriate times. And if you have a problem with dilation and constriction, in other words, if your body is inappropriately dilating, you're going to end up with low blood volume and a loss of fluid. So find the treatment and the cause, stop any external hemorrhage quickly. Absolutely, you've got access to external experts such as your intensive care paramedics who can give fluids, and they can also give colloids as well. For your normal fluids, your sodium chloride are called crystalloids, whereas your colloid is protein as well, and transferred to hospital rapidly. Now, hypo and hyperkalemia is not something we can actually measure pre-hospitally. We can kind of measure metabolic disorders because hypovolemia is a type of metabolic disorder. But when you're in cardiac arrest, your patient is going to be acutely unwell and the whole system's just blow out of whack. However, if if somebody's in a cardiac arrest because of hypoglycemia, then that's something you can treat. Now, the word hypo and hyperkalemia just means potassium. So for example, hyper is high, kalemia is potassium. The way I remember this, so for example, is if you look at Ka in kalemia, that's the chemical symbol for kalemia. So if you think about kalemia itself, is potassium. So Ka is the symbol of potassium, and that's how I always remember it. So Ka is potassium and Na is salt. And likewise, hypokalemia is low levels of potassium. Now, what you have to remember with any electrolyte is they are used to maintain a pH, which is an acid level of the blood between 7.35 and 7.45. And that's why these are extremely deadly to human beings. And that's basically it from hypokalemia. When you're reading around your advanced life support, you will read a lot around hypo and hyperkalemia in a lot more detail. Hypo or hyperthermia. Now, hypothermia, as you can imagine, is something that will start to make your body shut down very quickly, and it can even put you into unconsciousness and no signs of life after about 24 degrees centigrade. Now, as you can remember from your studies, normal body temperature is 36.5 to 37.5 degrees C, and anything below 36.5 is a state of hypothermia, and anything more than 37.5 is a state of hyperthermia, which are both quite bad for the body. But of course, hypothermia and hyperthermia are really difficult to treat in the pre-hospital setting. With hypothermia, your target is to try and warm them up, but unfortunately, all you have are blankets and the thermo blankets as well, and they're not that great at warming people up. Hospitals have a much better system, and of course, you've got to warm people up in a systematic and slow way as well. And in fact, for cooling them down, it's even harder. You know, all we can do is cut the patient's clothes off, because we've got to be very careful that we don't push our patients in a state of shock by pushing them into cold water. Toxins can be anything that is sufficient enough in volume to overwhelm the body and cause a systematic response. So that can include things like street drugs and even prescription drugs. When we think about overdoses, we always tend to think about overdoses of illegal drugs, but trust me, patients can just as equally, if not, there's a higher prevalence of overdoses of prescription drugs as well. Now, toxins can also be a massive systemic bacterial infection, such as meningococcal septicemia. And of course, paramedics can treat that with a broad spectrum antibiotic. And ambulance services all use their own slightly different antibiotics. But of course, for that, your patient must have the presence of the rash, which you'll notice, which is a sign of septicemia. And that's on the increase in Australia, particularly in the pediatric populations. So when you're treating patients with toxins, make sure you do get a good look at the pupils as well. Listen to the history taking, because the history taking, checking of the pupils, looking at the A, B's, and C's, in particular the breathing, are the biggest clues as to whether or not you're going to be treating somebody with a toxic overdose, drug toxicity. Remembering that drugs such as heroin will slow your patient down, drugs such as cocaine will speed your patient up. Now, cardiac tamponade is absolutely serious because it's actually a pooling of blood in the it floats around, the blood swells the heart and stops the cardiac myocytes from pumping, squashing the blood. Remembering that you've got different layers of the heart, the myocardium is in the middle, endocardium is within, and the pericardium being the outer space. So it's blood within the pericardial space, which, as you can see on this image, pushes the myocardium and stops the heart from pumping. Now, again, what this needs is a draining of the blood. Now, of course, we don't do that in a pre-hospital environment. It has to be done by specialists. Thrombus, again, is definitely a life-threatening condition. Again, we can't do a massive amount for these patients, but what we can do is we can recognize it and pre-alert the hospital and get them to the right care quickly. We can absolutely treat the cardiac arrest if the patient's still in cardiac arrest. And the thrombus is basically just a blood clot. So the word thrombus just means clot. Now, if the blood clot is in the lungs, it's called a pulmonary embolism. If it's in the brain, it's called a stroke or a CVA, cerebrovascular accident. And if it's located in the heart, it's a myocardial infarction. Tension pneumothorax is also something that can kill your patient. As with cardiac tamponade can be caused by blunt trauma to the chest. So can tension pneumothorax. So imagine that when you breathe in and out, the air goes into the trachea, but doesn't go back out of the trachea to be exhaled. Instead, it fills this pericardial space and actually fills up the space, the pleural space, not pericardial, the pleural space, fills the pleural space up and squashes the lung and eventually pushes everything to one side and stops the heart from beating. Now, these patients will be having signs of difficulty in breathing. They will have a mechanism of injury. There'll be signs of shock. And paramedics must be able to treat this using a 14-gauge cannula into the pleural space. Okay, guys, so I hope you've enjoyed this very short lecture on time-critical patients. We've looked at a different definition of time criticality. We've recognized certain features, and we've also looked at methods for managing time criticality. Now, this session really is it's a small session. Time criticality is a huge area of paramedic practice and even medicine. And the more you read, the better you are going to be at recognizing time criticality. However, I feel we've confidently discussed the key signs and symptoms for these patients. My name is Sam Willis, and I look forward to speaking to you again in other lectures.